let's finish up with the eyes. The last thing we're going to talk about is cornea disorders. So this is a pretty quick slide. Abrasions is just as it says, where there's a scrape or scratch injury of the cornea. This can be caused by something in the eye, like a pencil shaving, metal shaving, a pencil itself stabbed in the eye, trauma, contact lens use. So that's what I had, is I tried to keep my contacts for longer than required or necessary. And then certain cancer therapies as well, which we'll talk cancer later on. There can be an infection that's caused by anything, like you guys know, that causes an infection, bacteria, protozoa, fungus. An ulceration is a deeper injury caused by the infection, and this leads to an emergency due to blood supply being impaired. And then interventions is antibiotic eye drops, steroid eye drops to reduce inflammation, and then prevention education. So wearing eye protection if we're going to be anywhere near things that could fly into their eye. And I had another abrasion when I was a brand new nurse. The patient had a peg tube, and for some reason I was flushing it, and there was a backup that developed, and the peg tube juice came out of the peg tube and went right into my eye.
Ooh.
Yeah. Yeah. I'm like, oh, that's awesome. So I had an abrasion from that because I was not wearing goggles. I didn't think I needed to wear goggles with peg tube flushing. I don't know how it happened. Sometimes I'm not the most coordinated person. So
Do you goggles now, or do you just like turn the
I
camera
just
every
turned,
time?
yeah. I don't want to walk in like these giant goggles. But yeah, I just turn away now. All right, you guys, with that, let's do a little bit of application now. So let's do a case study, and then I'm going to talk about the test taking strategies before we do NCLEX practice questions. So here's our patient. FM is an 81-year-old Hispanic woman who comes to the ER with vision changes. She states that her vision looks like everything is covered with spider webs and a curtain is closing. What are you thinking right away? Retinal, partial or full? Partial, good. She reports seeing periodic light flashes and small white spots floating in the air. So we already answered this first one. What do you think are possible causes of her vision changes? So partial retinal detachment, right? What are some questions that you would ask her, thinking that maybe she's got a retina issue?
Any recent surgeries?
Recent surgery, good. Medications? Do you smoke? Diabetes? What health conditions do you have? Good. Okay, so all the questions. This is what she says and what her history includes. So she did have cataract surgery 2 months ago. She does have diabetes, and she does have hypothyroidism too, because remember, the thyroid hormones are linked to vision and eye changes. She's on glucophage for her diabetes, levothyroxine for her synthroid, and then metoprolol because she's got hypertension as well. She has had problems moving her bowels with increased straining, so increased pressure, right? She's trying to drink prune juice. She denies any eye pain, itching, or tearing. She does have difficulty reading. She's afraid she's having a stroke because vision changes could be linked to stroke, okay? So what subjective findings are most concerning to you?
She's straining.
Straining, what else? Previous surgery, good. What else? For stress, yeah, we have to reassure her, right? Hypertension, good. And so, in the diabetes, good. And when we assess her, we're looking for perla, right? We're looking at her external eye structures. We're looking at, does she have accommodation and convergence? All of the things that you know how to assess the patient's eye. So perla, no abnormalities noted. External ocular movements are intact and symmetric. The healthcare performs an ophthalmoscope exam and finds a partial retinal detachment. There it is. So what risk factors? We talked about this. Put the patient at higher risk. So type 2 diabetes, recent eye surgery, straining with bowel movements, right? And then what's a major complication if it goes untreated? Blindness. Good, a fully detached retina, right? And so the only treatment is to have the the surgery to reattach, where she's gonna lay head down for a certain amount of time to allow that gas bubble to go to the back of the eye and reattach the retina, right? Okay, any questions about that? You all aced it, good. Okay, speaking of acing, you can kind of sit back and relax for a second. Let's talk about some test taking strategies before we get into the NCLEX style questions, okay? So what I did is I looked in this, have you guys heard of this book, Saunders, NCLEX RN? It is a wonderful book. This is the only book I used to pass the NCLEX. Back in the day, we didn't have Archer, we didn't have UWorld, we had Kaplan, but Kaplan was $500. And I think it still is really expensive. Actually, on my Facebook memories, like this week, I posted however many years ago, is Kaplan review course really worth $500? Because I was contemplating, but I didn't have the money. I was a nursing student, you guys get it. So I used Saunders, and it was a book. It wasn't online. We had dial-up internet, so took forever. But this is a really, really good resource, and you can get it now. It has next gen in it, and you can use some practice questions, because like I mentioned day one, the commonly missed areas on the NCLEX for our seniors is basic care and comfort, what we're talking about right now, okay? This edition is the 9th edition. This is the most recent edition, and it has next gen in it. Another thing, it gives you access to like 1,300 practice questions. You can narrow down to fundamentals, to cardiac, to endocrine, like as you go through, OB, peds, all of it is in this book. It also gives you an outline, kind of Cliff's Notes version, shortened version of the stuff that you missed. So I really like it. It's like $50-ish on Amazon. It's not required for our class, but it will be required as you move through the program. So what I did is I took some stuff, there's a chapter in there about test taking strategies, and some of this you probably already know, okay? So first thing is, as you're reading the question, look for strategic words. So things such as early, best, most likely, essential, those are all asking you what is the priority, okay? Words that reflect assessment, such as monitor, gather, collect, those are questions that are asking you for assessment findings. When you're reading the questions, be careful with the positive and the negative. If you read too fast, you may miss the word needs further understanding, okay? Or indicates an understanding. So make sure you slow down when you're reading the questions, all right? So for priority questions, you know this, airway, breathing, circulation. If all of the patient's needs are met, airway, breathing, circulation first, then you go to Maslow's hierarchy of needs, and I have a picture to show you. If Maslow's hierarchy of needs, if their basic needs are met, which includes airway, breathing, circulation, then you go through the nursing process. So here's an example question. A patient with a diagnosis of cancer is receiving morphine sulfate for pain. The nurse should employ which priority action in the care of the client? So what does morphine do? Causes constipation, hopefully releases pain. Decreases respirations. Good. It's a narcotic. We're interested in their airway, breathing, circulation. Yeah, we're concerned about their bowel movements, but we're more concerned about their airway. So what option would you guys choose? D. Excellent. Encourage the client to cough and deep breathe. Okay, here's Maslow. You know about Maslow? Yeah. Basic needs are at the bottom. Physiological needs. Breathing, food, water. This is our airway, breathing, circulation. Then next, if those needs are met, then you're looking for a priority of safety. It's either gonna be airway, breathing, circulation, or something with safety. Those are your top priorities, okay? So after you read the question, you need to kind of ask yourself, what is this asking me? Put it in your own words before you look at the options. When you're looking at the options, things that you can eliminate are the close-ended words. All, always, never, get rid of them. There's always an exception to the always, never, all, etc. Okay? You can also get rid of the comparable or alike options. So for instance, here's another example, and I'll zoom in because I know it's kind of hard to see. So a nurse is caring for a patient who recently underwent a cardiac cath procedure. Which of the following must indicate that the nurse must notify the provider immediately? Okay, so pretend you're sitting in the NCLEX testing center right now. You're in this tiny little cubicle. You have this question pop up on the screen, and you're like, I know nothing about cardiac catheterization. What can you kind of think about with this question? What happens? What could be a complication? Bleeding, good. Catheterization is a procedure, okay? Because sometimes you're gonna get a question that you have no idea what it's talking about. So you have to break it down into, what do I kind of know about this? I had a lot of psych meds on my NCLEX. Psych was my least favorite. I didn't study psych. My clinical psych had C. diff. So we didn't even go to psych or clinical for 2 weeks. So, and once again, we didn't have virtual anything back in the day. So when I had psych meds that continued to pop up, I'm like, man, I failed this. I didn't. For some reason I passed, but I thought I failed. So just breaking it down to, what do I even know a little bit about a medication or about what the question's asking me? Okay, so it's asking me for immediate. So the patient's not interested in eating. The patient's femoral access site continues to bleed following applying pressure for 20 minutes. The patient's upset that he will need to lay flat and eat his meal, or his pain out is 3 out of 10.
B.
B, good. So this one is kind of a twofer. Immediately is priority, right? So we're looking for airway, breathing, circulation. Circulation is bleeding, so that's why it's B. But also, we can eliminate 2 of them because they're kind of similar. We can eliminate A, eating dinner. We can eliminate C, laying flat and eating dinner. Okay? For medications, you are not going to get the brand name on your NCLEX. You're not going to get low pressor. You're going to get metoprolol. So it's good to know generic names now. On your exams, it's going to be generic names. Okay? What is the relationship between the medication and the medical diagnosis? There are so many different medications, as you guys are well aware of already. So trying to understand common side effects for the med class versus individual medications underneath that class will help you tremendously. Focus on what the question is asking, meaning if you have a diabetic patient and they're on insulin, and the question is asking you for signs and symptoms of hypoglycemia from the insulin, giving too much insulin, or is the question asking you what are the signs of hyperglycemia because they haven't received enough insulin? So always focus on, what is this question asking me? Is it asking me for a side effect of a medication, or is it asking me for a disease process? Okay? So read every word. Figure out what topic is being asked. Visualize the event, but don't go down what I call the what-if pathway. Just read it as it is. Don't add to the story. Well, what if his labs were 20,000 for white blood cells and his platelets were 50? Well, then it would be this answer. Well, it doesn't tell you the labs, so eliminate that what if, okay? This can be really hard, especially if you work in the healthcare setting. Well, I've seen it done this way. When you're answering questions, you have to think of a perfect NCLEX hospital where everything is right next to the patient, okay? And then the options, so process of elimination, comparable or alike, remove the close-ended words, thinking about prioritizing airway, breathing, circulation, and safety after that. And then for a therapeutic communication, any type of question that involves what are you gonna ask the patient, it's more of an open-ended question versus close-ended yes or no. How are you feeling? Tell me more, like the warm and fuzzy, okay? So with our brief test taking strategies, now let's do some practice. So you guys have these questions. You may see some of these questions again. Hint, okay? So I wanna make sure you understand these. These are for all eye conditions. So the first one should be a nursing student. Is that your first one?
Yeah.
Okay. A nursing student is assisting an older patient who has decreased vision related to macular degeneration. The patient is alert, conversing, and cognitively intact. When would the supervising nurse intervene? So look at the options, take a minute, and let me know what you come up with. What do you guys think?
C. B.
Okay, I hear B, I hear C. Anyone think A? No? How about D? No? D? Okay, I see one D. Alright, so it's asking, when would the supervising nurse intervene? So when you ask yourself, what is this question asking me? It's saying, I'm looking for something incorrect, right? Okay, so looking at B and C, student talks to patient about family and asks, so when was the last time you saw your uncle? Okay. Or student closes the curtains, turns off all the lights at the end of the shift to encourage rest and sleep. When you think priority, I just mentioned airway, breathing, circulation, and safety. So thinking of safety between B and C, what are you gonna think? B. Good. They have macular degeneration, which is the loss of what type of vision? Central. Yeah. If we're turning off all the lights, shutting the door, closing the curtain, and they don't have good central vision, they're at risk for falling, right? So we wanna make sure that they have a well-lit area. Perfect. Okay, any questions about this one? All right, next one. During the early post-op period, a client who has undergone a cataract extraction complains of nausea and severe eye pain over the operative site. What would be the initial, this is another priority, initial nursing action? So take a look. D. Ooh, I hear all of them. How about C? No. Okay, so we can eliminate C. Why do we eliminate C? It's putting more pressure. Good. Turning them on their operative side is gonna put more pressure on that eye, right? Okay, so we all agree, eliminate C. Now we're down to A, B, and D. Okay, I hear A. How about B? Reassure the client that this is normal. Is acute pain after cataract surgery normal? No. So we can eliminate that, right? So now we're down to A and D. Initial nursing action, another priority. So they've undergone cataract, they have nausea and severe eye pain. You're going to notify the surgeon first. You're gonna notify the surgeon first.
You know, the reason I didn't pick A is because I hear Anna's voice in my head, don't call the
I know.
Well, she says to do the assessment first and then call the doctor.
Okay, so you did the assessment,
Yeah.
nausea and severe
Yeah, I
eye
hear
pain over the operative site.
I just thought,
On the antibiotics, so they're not gonna like
she
like
like
a
Yeah.
dangerous on their iPhone.
Yeah, we have to notify first before we intervene, especially when it's an emergency. This is an emergency. Severe eye pain and nausea, that is not normal. They could be hemorrhaging, okay? I know, Hannah's voice. The nurse is developing a teaching plan for a client with glaucoma. Which instruction would the nurse include in the plan of care? I heard it. Say it louder.
C.
C. Excellent. It is C. They're going to be on eye drops for the rest of their life, right? That's critical for the treatment. They need those eye drops because that decreases the pressure, increases their vision, and decreases the risk of permanent vision loss. Okay? You guys good with that? Alright. The nurse is performing an admission assessment on a client with a diagnosis of detached retina. Let's say let's say partially detached retina. I change this on the exam. So it's partially detached, okay? Which sign or symptom is associated with this eye problem? D, good, yeah. If it was a fully detached, then it would be total loss of vision. Yeah, okay. It is D, right in partial detached retina. Okay. The nurse is performing an assessment on a client with suspected diagnosis of cataract. What clinical manifestation would the nurse expect to know in the early stages of cataract formation? D. Excellent. What is diplopia? Double vision. Yeah. So blurred vision is an early stage. Okay. Eye pain is linked to that acute closed angle glaucoma, right? Floating spots is linked to what? Detached retina. Yeah, or partially detached retina. So that can happen in a late stage, but an early stage of cataract formation is blurred vision. That's where you have the opaque lens, okay? All right, which symptoms will a nurse teach a client who just had surgery to correct a retinal detachment to immediately report to the eye care provider? Select all. You're gonna start having some more select alls.
I don't like that.
I know, select alls. Okay, so let's talk about select all first. Treat each option as a true or false. Okay, true or false? Pain in the affected eye, they need to notify their provider. True. Pus in the affected eye. True. Decreased visual acuity. True. It's true. Temperature of 99. No. False. Pupil that constricts in response to light.
No.
False. Okay, so our correct options are A, B, and C. So treat each one as a true or false. Okay? Good with those questions, you guys? Okay. All right, what I want to do is let's just introduce ears and then we'll finish up next time. Okay? Hang on, let me think for a second. Do we have enough time? Ears is great. Are you guys, yeah. Is your brain mush or do you want to keep going? Keep going? Okay. Let's do a little bit of ears and then we'll stop. Okay. So, we did eyes. It's not that much. So we'll do some like our head. Yeah, it's not too much. We'll stop before Meniere's. I'll do Meniere's disease next time. But let's switch to ears now. And just like eyes, I have a quick video.
Have you ever wondered how sounds make their way from the source all the way to your brain? Take a trumpet, for instance. When it's played, it makes sound waves in the air. The outer ear catches the waves, which then travel through a narrow passageway called the ear canal. The sound waves reach the eardrum, which is a membrane roughly half the size of a dime. They make the eardrum vibrate, which in turn vibrates 3 tiny bones called the malleus, incus, and stapes. These bones amplify or increase the sound vibrations and send them to the cochlea. The cochlea is shaped like a snail and is the size of a garden pea. It is filled with fluid, and the sound vibrations make this fluid ripple, which creates waves. Hair-like structures called stereocilia sit on top of hair cells and are grouped together as hair cell bundles inside the cochlea. The hair cells inside the cochlea ride these waves, and the hair bundles are moved. The hair bundle on top of the hair cell turns these movements into electrical signals. As the hair bundles are moved, ions rush into the top of the hair cells, causing the release of chemicals at the bottom of the hair cells. The chemicals bind to the auditory nerve cells and create an electrical signal, which travels along the auditory nerve to the brain. Different hair cells respond to different frequencies of sound. The hair cells at the base of the cochlea detect higher pitched sounds, such as a piccolo or flute. The hair cells toward the top of the spiral detect progressively lower pitched sounds, such as a trumpet or trombone. At the very top or apex of the spiral, the hair cells detect the lowest pitched sounds, such as a tuba. The auditory nerve carries the electrical signal to the brain, which interprets the messages as sounds that we recognize and understand.
I know. That's why I always start back at the beginning. A little refresher doesn't hurt, right? You did? The ears?
That video would have
Ears and eyes. I know.
And I hated how you use surgical sets for it too.
Yeah. Okay, so just a couple different things. As the video pointed out, tympanic membrane is what? Eardrum. Yeah. So if someone has a really bad ear infection, that can perforate or rupture the eardrum, right? Also, if someone sticks something too far in their ear because they're trying to clean out the wax, and so they stick a Q-tip, a bobby pin, a safety pin, something like that, and it can rupture that eardrum, okay? And then they lose hearing, right? With our older adults, as always, we gotta talk about changes that happen, right? So the pinna becomes elongated. What's the pinna? The dangling part, okay? So when the pinna becomes elongated, if they can't turn themselves, and let's say they're on their side and it folds up, that can cause skin breakdown, okay? So you wanna make sure that the pinna is not folded under the head, because they can get pretty dangly, right? Hair in the canal becomes coarser, so they may need frequent ear irrigation. Cerumen is what? Earwax. Yeah, it becomes drier and can become impacted. And so ear irrigation, once again, may be needed because that can cause changes in their hearing. Tympanic membrane loses elasticity, hearing acuity decreases. So I mentioned that they have a hard time hearing high pitch noises, like their microwave, their alarm, like the higher pitch things is what they have a hard time hearing. So when we're talking to them, we may need to speak in a deeper voice where they can hear us better, speak slowly and clearly, and emphasize the beginning of word sounds, okay? Okay, there's two different types of hearing loss that I want you to know, conductive versus sensorineural. Conductive is when something is obstructing that sound wave coming in and going to the tympanic membrane. So something is obstructing that sound wave from hitting the tympanic membrane. So earwax, foreign body like a Lego, okay? If their tympanic membrane is ruptured, perforated, then of course that causes that sound wave to not hit it, and then an infection. So this is something on the outer ear that is causing those sound waves from not hitting the middle to inner ear, okay? If they have a tumor, if it's swollen, like I said, earwax and so on. So what you would see if they had conductive hearing loss is you can see the obstruction, you can see the Lego little head in there or Lego piece, or you can see the earwax crawling out of the ear, right? They're speaking softly and they actually hear better in a louder environment because that loudness is getting through that impaction, that obstruction, okay? Sensorineural is more middle to inner ear problem, where they have this prolonged exposure to noise. Presbycusis is hearing changes with older age. Presbycusis, circle that, is hearing changes with older age. so that causes sensorineural hearing loss. Ototoxic substances, medications that cause ear damage. I talked about furosemide on day 1. When we push furosemide too fast, or if they're on a high dose of furosemide, that can cause damage to the ears. Another one is high doses of aspirin. Aspirin can cause damage to hearing. Okay? Meniere's disease we're going to talk about later. And diabetes too, because it affects all components and vasculature in the ears. So when you look at their ears, there's nothing obstructing for sensorineural hearing loss. What is tinnitus? Or tinnitus? Ringing. Yeah, they have ringing in their ears, they're dizzy. It's because the inner ear is affected. Those tiny little ciliary, the hairs. They're speaking loudly, and they hear poor in a loud environment. Okay? So just to help you visualize this, I threw this picture in. So conductive hearing loss, so down here, conductive hearing loss goes from the outer ear all the way up to the tympanic membrane. Okay? And that's when there's the obstruction there, the earwax, the foreign body, and whatnot. Sensorineural hearing loss now is from tympanic membrane forward. So the cochlea is affected, the little tiny hairs are affected, okay? So no matter the type of hearing loss they have, for recognizing cues, subjectively, we're asking them these questions. Have they had any ear trauma? Ear surgery? Maybe they had their tympanic membrane repaired. How do they clean their ears? Because if they're using Q-tips and sticking that earwax further in, that can cause conductive hearing loss. What medications are they on? Because we know some can affect hearing loss, or hearing, I should say. Do they have exposure to loud noise or music? So me, I actually do have sensorineural hearing loss. When I was in middle school, I used to have my Discman, okay? We didn't have iPods. Discman is a CD player, portable CD player. You guys know what Discman is? Okay, all right. Or Walkman, I have both. So I used to jam music in my ears as I was walking to the bus stop. And unfortunately, my mom told me not to have it too loud, but I have hearing loss in my right ear. So when I'm like, huh, can you say it again? Huh? It's because I have hearing loss, okay? So exposure to loud music or loud noise, once again, occupation. What are they doing for work? And are they exposed to those loud noises? Do they have vertigo? Chronic and acute illness, so upper respiratory infections where they have fluid kind of buildup can cause hearing loss. Okay? Did you guys have Kathy for health assessment?
Yeah.
Okay, did she go through the Ryan versus Weber test?
Mm-hmm.
Okay, so the tuning fork test. Here's our Weber test where you put the tuning fork at the top, and if they can equally hear it in both ears, then that's a normal finding. The Ryan test is where you hold it behind their mastoid bone, right? And then you put it on their mastoid bone or something, I can't remember. You're not gonna be tested on it. Have you seen tuning forks in the clinical setting? No. Okay. What is one thing that you can do to assess their hearing though in the clinical setting?
The whisper test.
The whisper test, so how do you do that one?
You have them cover their
Yep.
ear and you whisper.
Yep.
Is it the opposite shoulder?
Okay, is it the opposite shoulder?
No, it's not. You have
So,
them cover their
cover?
ear and you whisper something over that shoulder and if they can hear it.
Okay, yeah.
The finger rub.
Do the finger
Finger rub test, what's that one?
You just do this.
You just do that.
And if they can hear it?
Yeah.
Yeah.
Oh, I've never heard of that one.
Yep.
Okay, interesting.
Yeah.
Okay, so there's different ways.
Like what do you?
Otoscope, were you guys validated in otoscopes in Skills Lab? So when I was in nursing school, we actually did have to get validated in how to use an otoscope, which is what you guys, if you go to the doctor, urgent care, or whatever, they stick it in your ear to look at your eardrums, if you have fluid and stuff. One of my peers actually perforated my other peer's eardrum because they went too deep. Yeah, yeah, in our skills lab. So maybe that's why we don't do otoscope anymore. So these things are more outpatient focused, but inpatient we can do the whispered ear test or the finger rub, which is cool. All right. So communication. Besides testing their hearing, what are some ways that you would communicate with someone who is hearing impaired?
Writing it down.
Writing it down. Good. What else?
Sitting in front of them.
Sitting in front of them so they can see you. When we had to wear masks at all times, for those that were hearing impaired, it was hard because a lot of them read lips, you know, and when we had a mask on because of COVID, they couldn't see, but then there were some masks that had like a transparent piece so they could see your mouth. So facing them, sitting down. Good. What else?
Speak slowly.
Speak slowly and clearly.
Pronounce your word.
Pronounce, especially the beginning of words. Good. Keep hands and other objects away from your face. I talk with my hands a lot. And so trying to keep your hands and objects away from your mouth when you're talking. So position yourself directly in front of them. Make sure that the room is well lit so they can see you. Move closer to the better hearing ear. Speak clearly and slowly. Hands away from your mouth when talking. Have conversations in a quiet room with minimal distractions, so turning the TV down. And then write messages on paper. Okay? What if your patient is fully deaf? Interpreter. We have to, you guys. We have to get an interpreter. There's like FaceTiming interpreters. There's physical people that will come in and be an interpreter for sign language. If we don't offer an interpreter, then that is a violation of their rights. We have to offer an interpreter. Every facility should have an interpretation service of some sort. Okay? Could be, like I said, FaceTime, or there are interpreters that will come in. Patients can request for an in-person interpreter versus on the FaceTime. Okay? Have to. All right, so early detection of hearing loss is important, especially if it's linked to medications. If it's linked to an infection, if hearing loss is linked to an infection, then we give them antibiotic drops, okay? Ear infections are extremely painful. I know they're more common in kids because of their anatomy, but I had a recent ear infection. Let me tell you, it was not fun. I had vertigo, severe pain, nausea from the pain. It was bad. If they have that sensorineural hearing loss and they require a hearing aid, then there's tons of different hearing aids available. There's just some pictures here to show you. On top of that, now hearing aids have Bluetooth in them, and so it's linked to their phone. So they can answer their phone with their hearing aid, which is pretty cool. Okay? So you don't have to know the specifics of hearing aids, like the different forms of them. But with hearing aids, we do have to educate our patients about maintaining them. So testing the battery, cleaning them. Hearing aids in the hospital go missing all the time. They'll stick them in their pillow, and then we change the linen, and there they go with the linen. Okay? So hearing aids and dentures are like the number one thing that patients are misplaced in the hospital. Nightly, we want to clean them as well, and then yearly, they need to get their hearing tested to see if they need a different type of hearing aid or whatnot. Another intervention for hearing is a cochlear implant. So if it is permanent damage, they can replace the cochlea, that snail, and it will help to improve their hearing. You guys may have seen like videos on TikTok or Instagram or whatever where the kids, in particular, mainly kids, have the cochlear implant and then they hear for the first time and they hear their mom or dad's voice and it's like, oh, every time I cry. It's so cool. Another surgery that they can have done is if their eardrum, their tympanic membrane is ruptured, then they can actually patch it with a graft. So then it will be patched and hopefully those sound waves will be able to bounce off. Yes.
My mom actually had this surgery done on both her ears.
The tympanic membrane one?
Yeah.
Okay.
It failed in 2 years, so
Oh.
she has conductive damage.
No way.
So she still has hearing aids, but like it doesn't quite work because she still has.
Wow.
They kept like trying to heal.
Uh-huh.
It wouldn't heal properly.
Oh.
Pressure.
Oh. Oh, I'm sorry to hear that. Wow. So, sounds like this isn't like 100% cure. Yeah. For hearing loss. Okay? Any questions, you guys? We're gonna stop here and we'll do maybe